Welcome to Voices in Value-Based Care. I'm Beth Houck. Thanks for tuning in. The shift to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this shift. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at BA Houck. On the program today, I talked to Brian Schatz, the Chief Operating Officer of Medical Associates in Dubuque, Iowa, about their participation in a Track 3 ACO. Brian, welcome to the program.
Thanks, Beth. It's great to be here. Appreciate being invited. Interesting topic.
Hey, no, it really is, and I think we're going to have fun talking about it. So, Brian, just for the listeners, so that for the ones that aren't from Dubuque, perhaps you can tell us a little bit about Medical Associates and where is it and what sort of scopes of services you offer and so forth.
Sure. Well, we're a multi-specialty physician-owned clinic based in Dubuque, Iowa. And Dubuque is this beautiful community right on the Mississippi River, and you can find us on any map where Wisconsin, Iowa, and Illinois meet. We're about 100 miles from west of Madison. We're about 200 miles east of Des Moines, 200 miles west of Chicago, kind of right in the heart of the country. Beautiful area. And Medical Associates Clinic is physician-owned from 1924, the oldest multi-specialty group in the state of Iowa. We have about 100 physicians and 180 total providers spanning 30 specialties. We've got a unique situation, too, where we have a wholly owned subsidiary health plan that takes care of about 45,000 members. And that health plan is approximately 35 to 40% of our total mix of patients that we take care of. So unique in that regard.
You know, I didn't think about it until you started telling me the mileages between the cities, but you kind of operate as almost your own little sub-market, like you can kind of own the market, if you will. Is that about right?
Yeah, I think it's interesting because we really are a kind of a protected marketplace. I would say it's roughly 70 to 100 miles to any similar sized or larger metropolitan area. That's kind of a rural area where Dubuque is sort of the hub, the economic hub of that zone. There's about 75,000 people in Dubuque itself, but in that kind of broader 70 to 100 mile radius, there's 150 to 175,000 people. So we're a little bit protected and isolated in that regard, but we've also got a pretty viable sort of economic area.
So good market to talk about relative to participation in an advanced alternative payment program because you have somewhat, some level of control over your market. So let's shift gears and let's talk about the topic that we intended to, which is your participation in a Track 3 ACO. So let's just to start off with, how long have you been participating in it? How long are you committed for? And then let's just move on to talking about your decision, how you guys made that decision to participate in it.
Sure. Well, we joined a Track 3 ACO that was effective January 1st, 2017. So we are roughly a year into it. That decision-making process was probably 6 to 9 months in the making and the active planning before that. And we joined an ACO organization structure that's part of Mercy Health Network Iowa and Trinity Health out of Farmington Hills, Michigan, where they've had a few years in various levels of ACO products and Medicare shared savings, but had initiated the activity to jump into a Tier 3 model, Track 3 ACO, effective January 1, and invited us as an entity, Medical Associates Clinic, and the Mercy Hospital partner, that's our local partner in Dubuque, sort of as a chapter of that Track 3 ACO. So the ACO itself holds a 3-year contract with CMS. Our subcontract with the ACO is also 3 years, but we actually have the ability to look at it on an annual basis. So it's kind of a sub 1-year term inside that 3-year term. So really gives us some flexibility, some added flexibility in addition to just the ACO itself.
What do you think? It's interesting. I didn't realize actually how far away Farmington Hills, Michigan was from your geography, or that was part of the whole thing. What do you think drove their decision to approach you? And
That's a great question. So Mercy Health Network Iowa is sort of a collaborative operating entity that is co-owned by Trinity out of Farmington Hills, Michigan, and also CHI. So a couple large Catholic health systems, and they're committed to the value-based healthcare model. In a lot of their markets, they have an employed physician base. In this particular market, they've got this huge independent, well-coordinated sort of multi-specialty physician group. And because of our health plan and our background, I think we've been operating as really an ACO-like organization for a long time, for over 30 years. So our experience, our track record, our comfort level with managed care, I think probably was some of the factors that made us attractive to Trinity and Mercy Health. Plus, they've got a lot of experience with us because our local Mercy partner here, we have 4 joint ventures with them in primary care, rural practices, our work comp, OC Health Clinic. They are a part owner of our third-party administrator product in our health plan. So a lot of history, a lot of understanding of each other that made the partnership sort of a very natural alignment. And I think they probably had confidence in our ability to operate well in this kind of a quality and financial risk model. And so we were worth taking a gamble on or joining with them in this.
That makes a lot of sense. I didn't realize all of the, kind of dry runs you had via these other initiatives that you're working on with them.
Right.
When you guys were making that decision, so you said it was a 6 to 9 month process, what were some of the bigger concerns that came up, or I guess unknowns that you were concerned about as you weighed the pros and cons?
Sure. Well, it's interesting because I actually think probably one of the biggest drivers of us saying, well, it's worth testing this and getting into this sort of model of APM, that 5% for 5-year, advanced bonus from Medicare provides some financial insulation, if you will, from the risk of making this sort of a decision and giving you a pathway and a corridor within which to make it. So that was attractive compared to Medicare fee-for-service with, plus or minus 4% and escalating from there under MIPS. Joining in with the ACO, they've offered us a level of financial risk protection for a period of time as well. We're sort of in a collaborative model with them. So that risk profile felt like a better bet for us in the near term, meaning 2 to 3 years, than a fully exposed sort of MIPS profile would have. Some of the unknowns, I would say, it's different for us. We've been an independent organization and had our own health plan for a long time, and we sort of operate in this 60 to 75 mile radius market, and we've sort of commanded our own marketplace. So it's different for us to jump into an arrangement with a partner that expands our Dubuque market into other markets. So I didn't mention earlier, Beth, the Tier 3, Track 3 ACO is operating out of a Dubuque chapter, which is us, a Des Moines chapter, which is Mercy's physician and hospital assets in Des Moines, and a Mason City, Iowa chapter. And so those 3 sort of, independent marketplaces of Mason City, Des Moines, and Dubuque are actually at collaborative quality and financial risk with each other. So I would say we know the parent, we know Mercy Dubuque, we know the parent company Trinity. We don't know the other operating entities, in Des Moines and Mason City as well. We've historically not had an overlap in patients per se, really not a big overlap in care. So that's a little bit of an unknown and a little bit of a concern going in. So that's been a learning process. It's interesting to be in clinical and financial risk with people you don't work with, that you haven't actually worked with. And so we're starting to build structures to where we can have visibility across the markets and see what the different entities are doing. Obviously, the logic and the argument is you've got the ability to cross-fertilize, better practices across bigger areas. We're also spreading the risk of the Medicare population across better areas. But Mercy Trinity was bringing to the table these 3 markets that they felt could be successful in this sort of higher risk, tightly managed model.
Really interesting. I've heard this a lot in the market, the whole notion of, you're kind of participating with, like you said, people that you don't necessarily know, but you're taking on risk. So you have to get along because that's going to benefit everybody overall. So it's kind of a new challenge in the market. I think it's going to be really interesting to hear how people are putting things in place to share those best practices while kind of retaining their own identity. Maybe a future program per se. So I think that one of the things you pointed out when you were describing your organization was that you're physician-led since, I can't remember, 1920 something. Given that, and given kind of the decision making as a result of that physician-led structure, what kind of information or education did you need to provide in order for your board to get on board with this?
Yeah, it's a very interesting question. We have an elected 7-physician board of directors. The officers serve 3-year terms, the directors serve 4-year terms, but we've got a high degree of continuity across. Some of the leaders have had multiple terms on the board, so we've got very stable governance leadership. And the fact that we've been sort of physician governed and had our own managed care plan for so long, the genre of accountable care organization is a little bit of who we are. So we don't have that hurdle necessarily to get over. If anything, I would say we're a little schizophrenic because we're like, half managed care ACO and half, the fee for service world, almost the worst place to be, where it's not all eggs sort of, you have to build structures to be successful in both versus just one. But in terms of this Medicare ACO model, I mean, we as a group have been participating in and talking about the various Medicare incentive programs since they originated. So, prescription, e-prescribing incentive, early voluntary PQRS or PQRI, and then PQRS, and the value-based modifier program and meaningful use. We were one of the initial groups in Iowa to be successful under, the initial set of meaningful use requirements. So in some respects, we've been a leader all along in that value-added space, probably because that's who we are, and we're a little larger and a little bit more organized. So we've been tracking and preparing for MIPS and this level of Medicare responsibility and reporting for years. So our organization as a whole is well educated. Staff, physicians, they kind of get meaningful use. They kind of understand what metrics and things we're reporting on. They understand the why behind it of where Medicare is heading. So that base level of knowledge is already well understood. So in this particular decision-making point, it really was a strategic analysis of MIPS versus APM for us. And it was really driven by the senior leadership team, of which I'm a part of, but really I would say headed up by our chief medical officer. And interestingly enough, the chief operating officer of our health plan. I mean, that analysis of we have risk-adjusted plans under the Affordable Care Act. We've got, at-risk populations that we're already at risk for financially and quality. We're participating in HEDIS and NCQA on the health plan side. We're reporting into Medicare. On the clinic side, where are we heading with value-based care? Those two individuals, supported by our CFO, really led the analysis. And then our senior management team took to the board. Our recommendation is that we jump into this APM, and here are the reasons why. And that body, the board, made the decision, and they're pretty well versed strategically. They made the decision, and then we communicated it to the group. So we didn't involve 100 shareholders in the analysis and deciding whether or not this was the direction we were going to go. But it caused me to remember back to like 2013 or 2014. We did an analysis of Medicare shared savings at that time, kind of when Pioneer was coming out. Maybe it was on the backside of that.
Yeah.
And we decided against doing Medicare shared savings at that time because the economics didn't really line up. Over half of our patient population that we take care of, half of our Medicare patient population that we take care of is the Medicare fee-for-service program, which, MIPS and APM would apply to. But the other half, and it's actually a little bit more than half, is our Medicare cost health plan group that's in our own health plan. So we've got this Medicare population spread across sort of wholly owned, wholly at risk health plan piece, and then the piece that goes up through the fee-for-service program in the federal government. So it's a little bit schizophrenic, and the economics, there wasn't enough bodies and enough people in that population back in the early stages of Medicare shared savings for it to really pan out for us. So we kept waiting and kept watching, and now coming together with these other two Medicare markets through Mercy, we've got really a bolus of covered lives that you can really do something with.
You use the term schizophrenic, and I think the whole market's going to kind of stay that way for a while, unfortunately. But I can imagine that part of coming to this decision was because it kind of puts one more arrow in the quiver that is aligned with what your health plan is already doing. So potentially, the COO that was helping to lead this decision, there's some halo effects that will occur by everyone, to use too many analogies, rowing the boat in the same direction, right?
It's a good point. Our chief medical officer, I'll just offer this, our chief medical officer is responsible for medical quality for the health plan and the clinic. And all of our quote unquote quality resources and our quality reporting is a function of his responsibility. So, really it's he and his team that have to rationalize reporting our HEDIS measures and doing our NCQA accreditations with reporting into Medicare and those programs. And so we've got this sort of natural overlap between the managed care and physician parts of the organization that already exists. It's kind of the chassis from which we work already.
So that kind of brings us to another line of questioning, which is around kind of startup. So it sounds like because of your foundational work and kind of what your DNA is as an organization, there's probably some infrastructure that you already had in place. But let's talk about some of the larger investments in time, resources that you had to make, in particular when you made this decision to follow the Track 3 ACO route?
Sure. That's a great question. We jumped in with Trinity's ACO, and they already had the IT infrastructure sort of under development. They had picked a technology partner, an analytics partner, IT, reporting partner, and we're building, the chassis for responding to their commercial and Medicare ACO products. So we didn't have to make extra independent investments alongside that other than what we were already doing. On our side, we have been making a preliminary investment in expanding our population health registry capabilities within the Cerner platform that we're using. So I think they call their population analytics platform Healthy Intent. And we made some investments in that, built out a handful of diagnosis category registries. So that work was already underway. And we made the decision when we started the ACO, we were going to keep both threads going. So we were trying to continue our investment into the Cerner registry platform and come alongside the investment that the ACO was already making in their IT infrastructure. Those were already going. I would say the biggest new investment is we made, point of care health coach investment. So we hired 3 health coaches that are specifically focused on the Medicare fee-for-service population, and I think our attributed patient number is like 6,500 or 7,000 patients. So these 3 nurses are 100% focused on that population, and we invested in their training and adopted the basic model and practice that was already in place with Trinity's ACO, and we focused them on the attributed population. So that's the biggest change for us operationally.
Was there sort of a model in place already related to the concept of health coaches, like that you learned from Trinity or learned from some best practices in the market, or did you guys design that from scratch?
Yeah, great question. We adopted the health coach model that Mercy Des Moines was already using, which was kind of the chassis for the ACO. But conceptually, it's embedded at the point of care, working alongside the physicians in the practice, identifying the higher risk population, and then focusing on them. And I would say that was a complement to kind of the case management and care management capability and coordination that we already had, but we had it primarily on our health plan side. And so on our health plan side, it was focused on the portions of our health plan products where we were financially at risk. So those were our commercial products, our underwritten commercial products. And it tended to be, health plan based versus at the point of care based. So the shift is health coaches at the point of care, and then we've tied them basically into the rest of our care management and disease management and I would say complex case management structure that we had with our health plan. All of these structures rolling up through our chief medical officer. It's kind of filled that last piece in the continuum, which was focus at the point of care on, where we're seeing the patients and the particular patients that need focus. Any
early feedback on that? So have you, in the market, have you heard from patients or other staff? What's been the response to that health coach model?
Well, it's interesting. Sometimes you're your own worst enemy. And, for us, it was a learning curve too. We've got very capable primary nurses and other things. And they saw, hey, some of the stuff that the health coaches are either talking about doing or could do is some of the things that we do, coordinating care for our patients. So we've had to work hard to communicate and to try to rationalize our own care model at the point of care. That's been learning for us. On the patient side, we're picking up things and filling holes in sort of the social fabric of how the patients get care inside the practice and outside the practice that, just frankly hasn't really existed. So you've got, higher at-risk people that tend to fall through the cracks between places of care like inpatient or skilled nursing or nursing home or practice. And now we've identified, literally those handfuls of people that need a little bit more focus and care, and the health coach is providing the connective tissue, is almost the way I would describe it, to ensure that services are validated and we're following through on the things that the patient really needs that have the biggest leverage for advancing the outcome of their care.
So you have about a year under your belt, just a little over a year under your belt, and that may not be enough time to have full hindsight, but if you're tracking some metrics that are telling you how you're doing or not, how does it tell you you're doing? Or what, now that you have the benefit of a little bit of hindsight, what have you learned?
Yeah, I think most of our learnings to date in this first year have been, operational learnings, starting to build the chassis of health coach and married up with IT. The IT build, it's one of those things you kind of wish you would have started what you needed 5 years ago, but you didn't know what you needed 5 years ago because the requirements continue to shift. So that's never, where it needs to be. So we're still at the point where, we're a year into the operation. We've got scanty view of, the quality performance of the ACO as a whole. We've got a little bit better view of our own piece of performance. In terms of financial performance, I don't think we're going to really be able to see that until we're about mid-year 2018. We're going to be able to see 2017 more clearly. And this is even in the new model of, prospective attribution, which was frankly a problem with the earlier shared savings models.
Mm-hmm.
So we know the patients we're responsible for, but yet sort of the full quality and financial accounting of that just takes so long. So to be completely, transparent with you, it feels a little bit like you're flying blind. You're trusting some of your core processes. The information that we've seen so far, we believe that we're breaking even financially, but the proof is in the pudding on that. And I think the 5% payments don't kick in until operationally next year, 2017 year paid in 2019, and so we won't get some of that infusion of extra operating capital that to subsidize the investments we're making until later. So it's kind of interesting model.
It is, and such a CMS model. I know that's in the field. We hear that a lot. We're not going to find out enough information in order to shift gears fast enough. Like, time will have already passed. So it's a challenge. So if you feel like you can, so at this point, if we were giving advice to the listening audience that's trying to make the same kind of decisions about whether or not they should stay in the Mips track or go down an advanced alternative payment model track, or just in general, maybe they're looking more deeply into track 3 ACO specifically, what kind of advice would you give people?
Well, I think that's a great question. For us, it's been about clarifying the various metrics in the various, products and areas that we're responsible for, and understanding where they overlap and align, and then trying to figure out what our best levers are. So there are metrics that span our HEDIS commercial population and our Medicare population that are meaningful to the Medicare side. I think we counted somewhere, 60 or 70 different measures that we as an organization, track and report on in various ways. You obviously can't simultaneously improve 70 things. So it's about focusing and clarifying which are the ones that really matter, or where are the biggest levers that we can pull. And let's focus on a few things really tightly and try to do them well. For us on the patient care side, speaking of the Medicare population, that has really become the focal point of the Medicare wellness exam, because a lot of the questions and measures that we're asking about or tracking on the Medicare population are in that exam. And so we're really focused on getting people in, getting our percent of Medicare people that have gone through the annual wellness exam higher, because then we know we're getting them in and we're seeing if we have gaps in those measures. And that's also having, a positive effect on other metrics that we have to report. So we've picked Medicare wellness as a focal point. I think that's a place I'd advise people to start. And then back to the big picture of simplify and clarify your focus and pick a couple of things to focus on. It's very hard to move 100 physician group all in the same direction. So we find we're constantly clarifying and simplifying messages. If you can focus on two things, do these two things. Get the patients in for the Medicare wellness exam, and focus on these two meaningful use measures. Let's be successful on those, because we know where our gaps are as an organization, and we're just trying to get, the boats aligned. I think those are two of the bigger things I would say. The third thing that pops into mind, Beth, would be if you have, every physician group's got a Medicare population, they probably also have a larger commercial payer that they're doing business with. Obviously, if they have a commercial ACO arrangement, you want to work to align the measures across your commercial ACO product and your Medicare one. So if you need to work with the commercial payer to try to do that, try to get those rationalized so you can focus on fewer things and do them well. That's where we're putting our energy.
Thanks. I know that this is always going to be challenging partially just because anything that's new is going to be challenging. And I think your advice in particular about focus is key. We work with a lot of physician practices where trying to get them to narrow to the three things they need to focus on is the biggest challenge, because you can't do everything. Well, right. I think we're just about out of time, but I just want to thank
quickly.
You. I know, it's kind of fun. And there's 10 more things I would want to talk to you about. So I just want to thank you, Brian, for all of your time, all of your insights and great stories about your organization. I want to thank our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com. And if you liked something that you heard or had some thoughts about something you heard, please lend your voice to the conversation on Twitter using hashtag #VoicesOnVBC. And be sure to follow me on Twitter @BA Houck. I'm Beth Houck. Have a great week.